chat. Oh, thank you, Rana. We would really appreciate it if you could put your name, your pronoun, and what town you're from in the chat. That would be fantastic. And so we could see where everybody is coming from or which location, not where. Apologies. And we've been kind of discussing as everyone was kind of filing in what legislative updates we did have. So far, I haven't heard anything on a positive note, I have to say. But I may not be paying attention to anything positive these days. But David, if you have anything to add for legislative, you can. I will say that our bill has pretty much been killed for the Husky for a single payer universal health care system. Study bill has been killed, and David, you can take it from there, please.
There's not much to add. Basically today was the death sentence on the bill. It wasn't raised. We couldn't figure out what was on their agenda today, yesterday until probably late afternoon with many committees. So they're not very, they don't make it easier for us to follow the bill's itineraries. But today was the end of raising concepts and raising bills, period. And so that's it. Unfortunately, the sad news is we're still not going to get our study. That is such at a small cost for the, there might be a way to, I might be the worst legislator for that since I'm such a troublemaker, but a legislator that is close to leadership could always get some language that never went in front of public hearing included in the implementer at the end of session. So it's not really the fair game, but everybody uses that. And it's not transparent to the public. It's not, and I'm thinking we're only asking for a study. It's under $20,000. And I don't know, I have to look into this being able to be added into the implementer at the end of session. But yeah, if I ask now, I'll have to be a really nice legislator with leadership in the next couple of weeks, and that's not happening. So I won't ask now. But maybe I'll have somebody else to ask.
Yes, thank you. I don't want you to be nice. I'm tired of everybody being nice to these legislators. They don't do what we pay them to do. They don't speak for the people in their districts. So I don't want to be nice anymore. And unfortunately, I've been told from my paying job that I have to be nice. And I don't want to be at all anymore. So this is coming up into a conflict for me. I have no respect, none.
Well, we already know that if we're not nice enough, that there are ways that people who are in power can make us pay for not being nice, and it's not a level playing field by any means.
Okay, so I've assumed that we've all introduced ourselves in the chat, and I don't think, does anyone else have any other legislative updates that they'd like to share, perhaps on a positive note? Ellen, did you get a bill number yet, or?
I do, and actually I have good news. So, but I didn't know how to say that.
You want to wait until your presentation then?
Yeah, maybe.
All right, cool. All right, besides Ellen, does anyone else have any good news to share? Anybody?
I don't have good news, but even before this session, we had discussions with Representative Michelle and within Medicare for All Connecticut that if we did not get a study bill through the legislature this year, that it's a small enough amount of money that we can create, fund our own study and present it in future attempts to get legislation. So I think people can expect that to be a path that we'll be taking, is to get funding to authorize a study. And, once there are the numbers, we don't know exactly what they'll be, but we do know that a statewide single payer system would save money and give more people care. We know that. We just don't know the details, and we don't have the data to share yet. But so that is the path forward at this point.
Yes.
I have a question. I've been a little aloof and I haven't been on many meetings. My husband he's now undergoing his 4th cancer treatment.
Oh, so sorry.
So I am very familiar with the system. And he's on VA plus Medicare, and VA is a kind of a model for that. There's a single payer, you go in, and they're really nice. I walk in and I'm like, who am I talking to? You're really nice. This is not like where I used to work. So, and being retired, I have no qualms about talking to legislators. And I don't know why we have to study what we already know. I'm sorry, but that's just, I've spent a lot of time in research studies at Yale University. And this is not something we really have to study. We know it works. I mean, it's one call, one person, and being involved in Medicare Advantage, Medicare, VA, I've had a lot of systems, and I've had most of my patients were Medicaid, Medicare patients. And it's absolutely ridiculous why the single payer doesn't come. But as my husband, who is an MBA, says to me, are you kidding? The insurance companies are not going to give it. And Medicaid Advantage, they're all just funded and controlled by insurance companies. So the legislatures are not going to fight that unless we bring them to a head and say, why are you making money for insurance companies at the expense of care?
And I will answer that very simply for you, Sharon. The medical insurance companies in Connecticut have gone and made threats to our legislative offices, our legislators, the people in power, threatening all kinds of things. They've paid millions and millions and millions of dollars into lobby.
Yes.
So that has happened. And by the way, the study done at Yale was not based upon Connecticut. It was based upon nationwide, not Connecticut specific. And when talking to legislators, they want brass tax dollars specific to Connecticut. They don't care about nationwide, even though we know that. They want specific information to Connecticut.
And we can't get somebody, a Yale student or a Harvard University student.
No, we need somebody who knows what they're doing and has done it before. And we do know who will do it and how much they will charge. And
gotcha.
Sorry. No, that's okay.
Been a little lost.
No, that's okay. It's perfectly fine. And we appreciate the questions. And he does this for municipalities. And we have spoken to him, and it is about $15,000 to $20,000. He charges $15,000, but in order to make sure that other Connecticut entities are involved, like say UConn or something like that, that would just be an extra expense. So we cushioned a little bit more money. That's what the issue is.
Okay, thank you.
You're welcome. And Tom, go ahead, please.
Yeah, and I apologize in advance. I was up at the legislative office building today and I feel very brain dead, but I'm just curious, and you have probably explained this in other meetings and I'm just forgetting it, but I've always understood, and again, I'm going to preface this, I wouldn't be here if I wasn't behind this. I think the current, healthcare industry is so corrupt, it just makes me ill every time I think about it. Having said that, though, the name of this group is Medicare for All. I've always considered Medicare a federal program. Is there some other state that somehow has crafted something piggybacking off Medicare to do what you guys are trying to do? Because normally I would think it would be like a Medicaid waiver that might be a better avenue. And again, I apologize. You probably covered this and I just don't remember it.
Well, because we know, especially in the current situation, that federally this will not happen. We are trying every possible avenue that we can. So we are going with trying with state-based universal healthcare. So it would be, so even though we are Medicare for All Connecticut, we have tried doing our municipal resolutions to send strong messages that our towns and our cities want this, and to send it to our Senate districts and federal, to make sure that our legislators know that their constituents say that they want Medicare for all.
Okay, so that's the strategy, is to get the
Correct.
noise level cranked up
Yeah,
at the town level to echo back into our, federal legislature.
right. But
Gotcha.
we
All right.
feel
And
that Connecticut is very ripe and ready and can go right away into a single payer system, because it's already passed, I believe in 2000, sustenance was already passed. Now we don't agree with the mechanisms that were set back then, or some of the things that were set back then, but we agree with it on principle.
Gotcha.
And I
All right.
have those two experts here who would be able to help us out with that kind of stuff.
Well, I know
but,
between Sheldon and Ellen, they can set us all straight.
Correct, yes.
Yeah, and even the municipal resolutions, some of them throughout the state do include also for a state level single payer
Correct, yeah,
system in their resolution. So it's not only
Yes.
federal, but for also, yeah, kind of
absolutely.
Medicaid for all, sort of.
Yes, yeah, so Tom, we like to call it Husky. We did call it Husky for All at first because Connecticut recognizes the Medicaid program as Husky, and it's
Right.
not really Medicare for all, because a lot of people don't, yes, exactly, state single payer. People don't recognize Medicare or want Medicare because they think, oh my God, that doesn't cover everything. So it's not as well understood that what we want is expanded and improved Medicare for all. And instead of explaining that thoroughly, if you say state-based single payer, then they understand more what you're trying to accomplish.
Gotcha. All right. Thank you.
Yeah, quickly. Yeah, the terminology is just really challenging.
Yeah.
Medicaid sometimes for some people has a stigma that it's just insurance for poor people. Medicare doesn't have that kind of stigma, but doesn't cover a lot of essential medical needs like vision and dental and et cetera. So it's it has real limitations, and and single payer, people will think it's socialism, so to get the right name, it really is in small part a PR issue, like how to frame it to get most support for something that we really need.
Gotcha. And again, I'm with you. I mean, everyone needs this, not just the state of Connecticut. It's just obscene what the insurance companies have gotten away with all these years.
Agreed. And it would also help to streamline a lot of the redundancies in all of these siloed services that we are given to our state. Each of these siloed services, a lot of those can be broken down too. Yeah, David, double. Okay, so now I would like to go on to our presenter, if there are no further questions. Tonight we have with us the amazing, the wonderful Dr. Ellen Andrews. I can go on and on about her many, many achievements, and I shall in a moment as soon as I can pull them up in my calendar. My apologies. So Ellen, like I said, helped do and set up our current Medicaid system with Sheldon, who's also here. They fought and fought for us to get the private insurance companies out of our public Medicaid system. And thank you guys for doing that. And thank you for all of your continued work and the amazing things that you guys do for us. I know I'm saying that I really want to get out of all of this today and stop fighting. But I think if you guys have hung in here to continue to do this, maybe I'll keep pushing forward. So Alan leads the Connecticut Health Policy Project since 1999. She also happens to have a PhD in human genetics from Yale University. So just to say a few things, Alan is absolutely intellectually gifted, and thankfully she's on our side. So Alan, please go right ahead with your presentation.
Holy cow, no pressure.
Are you going to want to share your screen?
I'm not going to. I didn't do slides.
Okay.
I hope that's okay. But I like to be able to see all of you, because I can tell when people aren't, picking up what I'm saying, and when it's just that tiny sliver, I only get to see another 3 other people. So I prefer that. And just for a little context, I know it sounds awful, Holly, that, like Husky for Immigrants is going slowly year by year, but it took Sheldon and I 12 years to get the managed care organizations out of Husky. It was a very dark and lonely and ugly 12 years. And there was no interim progress. It was just when it was just like one day we got invited up to meet with the appointed OPM director under the Malloy administration before they even came in. And he said, so tell me about your this PCCM idea you have. Like, okay. And then a month later it was announced. So, and a year later it was implemented. So it can happen. You just have to hang in there. And when I was going to give up, Sheldon held me up. And when he was getting up, I held him up. And so it can happen. And I'm not saying that, Medicare for all is cake. It's not. It's so not. But it can be done. It can. And eventually it has to be. So, but I will start with very, very tiny baby step that we've been working on for 2 years now. This is the second year. But it looks, and I thought, when I called you or emailed you to come and talk, I thought, okay, we're starting to grind again, and we'll, to try to get through. But this year, I was shocked. The day before the governor's budget came out, I heard in a rumor that he was going to put it in his budget. I was like, okay, I don't really know what to think of that, but he did. So the idea that I talked to many of you about last year, it's consolidation, the huge, consolidation of our healthcare system has created these 2 fiefdoms that are just eating up, gobbling more and more of our state and creating these monopolies, especially in individual areas. You don't even have a choice. Like, in some places you have a choice between the 2. I live in New Haven. I go to a Yale doctor because you don't have a choice. And so it is apparently too hard to unravel that. I don't know why, but I'm told that that's like an impossible thing. So we started to look at what we could do to make the market more consumer friendly, to give people choices, to also keep them from using their monopoly power to raise prices. And the things that I found were these bills that have passed in Massachusetts, where they are saving money. They between 5 and 20% on their premiums already. There will be a Q&A. Good. Off of their health plans. They had really high health plans, not like it's super cheap now, but it's a lot better. And Nevada just passed the bill too. They haven't really implemented it yet. So other states are doing this. The consolidation is the main driver of rising prices. It's even more than drugs, believe it or not. Now we haven't hit the multi-million-dollar gene therapies yet, so they may overtake. But anyway, the hospital prices are what a large part of why healthcare is not affordable in Connecticut. It also affects consumer choice, all those birthing centers closing down as soon as those hospitals enter into these big conglomerates. They're not profitable, so they shut them down and make you travel 3 counties away to have a baby. Staff turnover has gotten much worse. We had testimony about that last year, and they are just not investing in the people that they need to keep people safe, to keep patients safe, but also to keep staff safe. And it has had, despite what they claim that they're increasing quality, that you get better access to care. It is not true. There is either no impact or it goes down. And there are multiple studies around this, and it's never been found that it improves quality. And so the bill, there are two bills this year. One is the governor's bill is 983, and the insurance committee's bill is 6620. And what the bill does is it prohibits certain kinds of clauses in contracts between payers and these large health systems, that they cannot do 2 things, actually. When will Ellen be quiet? Okay. The all or nothing contracts clauses are when they, for instance, Hartford, this is the subject of the class action lawsuit against Hartford Healthcare. They have a hospital, for instance, in Charlotte Hungerford up in the, I'm sorry. Okay. Anyway, they are anti-competitive clauses that allow them to say you have to take our hospitals at any price we want. The other one is tiering, where how they have tiers, like the comptroller's office right now has the Centers for Excellence, and they where they provide better, if you were providing better care at a lower cost, you get to be in a better tier so that consumers don't have to pay as much. The cost sharing is lower. Well, if they're a monopoly, they can say, we want to be in that tier even though we're not better. And they can just get away with it. So the law makes that illegal. So this would make both of those things illegal. And it is an access issue because of the closing. And there are some poison pills, but I won't talk about those. I'll get back to the questions real quickly. And last year, the bill passed insurance unanimously, passed the Senate 29-4, but it died in the House. So we're really hoping that it gets through in the House this year. So I can stop now and take questions.
Those people were not people, they were trolls or something. I apologize for that. But
Oh,
if any of our real people have questions, I'm sorry.
no problem. It's one question is the governor's bill is 983. The insurance committee's bill is 6620, and they don't really differ from each other very much. They're a model bill that is the same bill that passed in Nevada and Massachusetts.
So would it help us to contact our governor and the legislators to support this bill directly?
Absolutely. Yes. I mean, last year you guys did, through your system, actually put in testimony. I don't know, there's no public hearing yet. I just checked the end of today, but I will let you know when there is. Yes, it would definitely help.
Yeah. Okay.
So if we were to just do that, Ellen, right now, without there being a hearing, who would we send it to? It would go to just the governor, and who else?
Well, probably insurance chairs. And somebody asked who sponsored the Senate bill. It's not a Senate bill. Well, it is a Senate bill, but it was through it's an insurance committee bill. So I guess Senator Cabrera put it in. Senator Looney co-signed it. There were several co-signers last year.
So would we target the whole insurance and real estate committee with letters of support?
That would be awesome. Yeah.
Okay.
I've been calling them, but yes, that would be awesome.
Okay, and the governor too?
Yep.
Okay, all right, cool, because that's how we can set it up. in the
Yeah, because the governor, 2 years in a row, he has put in a bill on drugs to claw back if they raise the price of drugs more than 2%, or more than inflation plus 2%, then they would tax back that extra. That I call it the anti-gouging bill. I don't know what they call it. But the governor's office hasn't really leaned into it. Let's put it that way, in terms of trying to get it through. So it would not be bad to give them a little boost.
And whoever this, I'm sorry, who the senator, Senator Looney, and who else?
Senator Cabrera is now the insurance chair. And then also Kerry Wood is the representative chair. And she's very supportive. Senator Cabrera sounded like he was. I don't think it's going to be hard to get it through again. I mean, the Senate hasn't changed it that much, not 29-4. It's just making sure that it gets through the process. Also, the Hospital Association didn't try real hard last year to kill it. Honestly, our biggest opponent was the Office of Health Strategy, but there is new leadership there. And I spoke to the new director and she was very supportive. And there are a couple of pieces in that bill that are basically poison pills, and I won't go into why they are, that they would exempt like for instance, one exempts them if they're an accountable care organization. Well, they're all accountable care organizations. So it would make the law pointless, and she got that. And so we're talking about how to fix the language so that that doesn't happen. She clearly didn't want that to happen. The previous administrator did.
So we can set it up to get sent to the entire insurance and real estate committee and the governor.
That'd
And
be awesome. Thank you.
and anyone else you think we should send it to, just please email me and I will have that added as well.
Great. You
Okay.
bet.
Thanks.
You
Anything
give
else
us-
we can do?
I think that's good. I mean, if we can get that through, I'd be really happy. I think Maggie has her actual hand up. Oh, no, she has her hand too.
Yeah,
Yeah.
I really want to talk. Let's see, can you hear me?
Yes.
Oh, perfect. Can you give us a few regular people talking points?
Sure.
I mean, so that we understand a little bit more. And does the drug gouging bill or the clawback bill, is that been presented this year?
No, it hasn't. He has other bills for drugs, but in terms of talking points, I'll answer that first. That's a good point. I'm going to write this down to do talking points. There is a fact sheet and a list of more research than you really probably want to read, but that I think was sent out. I think Holly sent that out, but we can resend it. But basically, it doesn't allow them to use their monopoly power to lower quality, reduce consumer choice, and most of all, to raise prices. It takes that away from their ability to do that away from them. So, I mean, they can consolidate if they want to, but it's not going to do them as much good as it did before. I think
And
Phil had his hand up.
Yeah, Rana and then Phil, I think.
Okay, this isn't exactly a question about what's happening here, but when we started publicizing this meeting, I was contacted by a couple people in other states who I know from the One Payer States group. And I guess in Minnesota, they're having a different consolidation threat, that there are two gigantic healthcare systems that are trying to merge. You know, kind of if Hartford Healthcare and Yale decided to merge.
Well,
And some of them were thinking about coming to this meeting tonight, but I did tell them that our problem hadn't gotten to that point. But if I come across them again, are there any provisions in this bill we're considering in Connecticut that might protect against that dynamic where there are two giant systems and they want to become one, super gigantic system?
Yeah, there's actually a couple of things happening with that. That happened in Rhode Island, and the FTC, the feds, came in and said, no, you can't do that. That they would take over the entire state. I guess in some ways we're lucky we have two systems. I guess there's a little tiny bit of competition. Sorry. But there are troubling signs of Yale and Hartford getting together on different new projects, different facilities, and cooperating. And, you know, when I started, they couldn't be in a room together without spitting at each other. I mean, they always had to have separate meetings with the legislators I worked for, which was just stunning. But now they're actually working together in ways that, you know, send chills up my spine. This bill would, however, even if they do merge or start collaborating, this bill would still make it so that they can't at least use their full monopoly power. I'm not going to say it's a silver bullet that fixes everything, but it does take a lot of teeth out of their out of what they can do. And I think I didn't finish talking with Maggie about drugs. The governor has not put in a clawback bill again this year for drugs. He wants to do, they had a list of some really good projects, and he didn't pick as many as I would have liked, but they're doing, they want to, I know I'm blanking on, there's one that's really, oh, that's right. The Array RX is this project between states that used to be just for states to purchase together drugs for like state employees, for Medicaid. Well, not Medicaid gets a better deal, corrections. This one would allow private people who don't work for the public sector to also get into it. Employers, but also individuals to be able to buy at that same price. So you basically get a drug card that you could buy things at a better price. And they already have half a dozen states that are involved in it, and they're trying to add more. And Connecticut's very interested in that. The other thing they want to do is the drug reps who go around to doctors' offices, you know, peddling stuff and coming with coffee and lunch for them. They want to license them and basically make them get some education about, you know, what they can say and what they shouldn't say, offering both perspectives. I'm not really sure how much, you know, difference that's going to make. And, you know, it's nice to make them certified and, you know, get a license or registration or whatever, and have to get at least some training in, you know, telling the truth about drugs. But once they get into that office, they're going to do whatever they do. So I'm not sure how much that's going to matter, but those are kind of their two big things.
Is it true that they're going to have a certificate about wine pairings to get their drug rep license?
I don't know, maybe. I might have to get a license. Yeah, I think that just sort of seems like, you know, harassment. Not that I have a problem with harassing drug reps, but I don't know how meaningful that's going to be. But I guess some drug rep really pissed off somebody in the governor's office.
Good.
But it's something, you know, it's like, I know it's not Medicare for all. It's not Husky immigrants. It's not what we want, but it's something. And I've just lived through so many, you know, I realized that when I wrote my op-ed that there are things to like in the governor's budget. This was the first time I've ever written an op-ed like that. The first time ever I've ever written. I mean, I started working at the Capitol the same day John Rowland started working as governor. And I have never had anything but a hostile administration. So I'm actually feeling good. I'm sorry, Holly, but I'm feeling good.
Could you tell us what things you like in the governor's budget so I can write them down?
Sure, I like that. It's actually in my op-ed if you want to look at that. My CT News Junkie, the last one I did, has them all listed out. But this I like the drug stuff that he's doing. They want to put more, it really ticks me off that they keep hiring. First of all, they hire terrible consultants like Baylett at OHS, can't do anything without, you know, hiring consultants. What they want to do is hire actual data analysts who can make their data so that it's actually useful and then actually answer our questions. And they would work for the state. They're not, you know, cutting and pasting from wherever they last were. And then when you finally get to implement something, they're long gone, you know, then it's the rest of us who have to fix it. I like that. I know it's small. It does sound really small. I'm at Medicare for All, you know, and I'm talking about not even baby steps. This is fetal steps.
Every little bit helps, Ellen. It's a positive thing. And so that makes me happy.
Good.
I was trying to find Ellen's op-ed and I couldn't get there quick enough. I'm sorry, Patricia. I was looking for it.
Let me see.
So on the drug reps, I've retired, but I have 47 years of drug reps trying to get to me and my staff, and Yale University, who I work for last, would not allow drug reps at all.
Mhm.
It was so nice. So
Yeah.
when it starts coming from institution, office by office, that's another way to handle it, because it relieves the providers from having to interrupt your day and take care of your patients, which you're supposed to be doing. And I don't care about your samples. They don't mean a darn thing, because they don't take care of enough people. And they're always pushing the more expensive stuff that, well, none of my patients could afford. And when they were pushing narcotics, I had a sign in my office that no narcotics, no benzos. And they go, what do you got that for? I go, you can read. So don't bother me, because I don't have time.
Right.
But I was really ostracized, and my bosses would tell me I had to be nice to the reps. And I just say, yeah, but I think that's another way to go. And I think it really helps if we can get providers to say, like Yale University said, get them out of our office, get them out of our hair, get them away from our patients and us, because they interrupt your care.
Yep. No, I agree.
It would be hours. It was a mess.
I went to speak to a hospital. I don't want to say which one, but they were having care management day. And this was when we were working on PCCM and Medicaid. And I went to give a talk, you know, and I thought that's great. And, you know, they had a whole spread and they for their nurses and their care managers. And I said, well, that's really nice you do this. And she said, oh yeah. And, you know, and we'll have a check for you, an honorarium. And I said, oh, well, that's very kind of you, a donation, whatever. And then she said, yes, it's all being paid for by, I think it was Pfizer. And I said, oh, thanks. No, can't take it. And I would have said no if I'd known, but they do these things and they get amazing, you know, good vibes from the staff. I mean, it works. That's why they do it. It works. The little pencils and stuff just get people to prescribe those things. And then if you get prescribed something in the hospital, you know, if it's a brand name, when you get out and, you know, it's been working for you, you're not going to change it back to the generic or something else. You're just not going to take that chance. It's a way to, you know, make more money.
Yeah, I brought two companies up against a ethics committee at one hospital I worked at. I said, what they're doing is unethical. And I was a nurse practitioner, none of the nurses wanted to talk to me after that. They ostracized me. They tried to get me to quit. They told me I was bad. They would set up pranks in my office because they lost lunch. They lost theater tickets. They would take them to the formula companies would take them to the Schubert.
Yeah.
So there's very subtle ways that merchandising and does that. But if you get them out of there, it's really, makes it.
If the bill had been, you know, we're not allowing these in license in Connecticut, you can't have drug reps, and then I would have been all over it. But sort of.
Yeah, just to give them a license isn't doing anything. That's just feeding them another avenue to get in.
Right. I agree.
Does anyone else have any more questions for Ellen? Or Ellen, do you have anything else you need us to help support with, or anything else that we can do?
I don't think so.
Because we don't
Really
really do action.
there is. I mean, I'm mostly working on, I'm gonna be putting out a Husky op-ed on Husky for immigrants, working on drug pricing. I did one recently and I'll do another on that. Yeah, I'm working on other people's stuff too.
Cool.
Yep.
Sheldon, I see you unmuted. Do you need to discuss something?
At some point, but I don't want to interrupt Ellen's presentation and questions there too.
Oh, Ellen's done.
Go for it, Sheldon.
So I had three things. It's probably illegal to have three different comments, but I always try to make it two. But first, Ellen is forgetting history that we actually won the battle to get rid of managed care companies running the Medicaid program initially when I was involved in litigation to subject the insurance companies to the Freedom of Information Act, private companies subject to the Freedom of Information Act. And we won in court, and we pushed, and we had Blumenthal on our side and others pushing the governor to say, well, since they won in court, you have to put in the contracts with the managed care companies that they have to be subject to FOIA. So all their books have to be open to anybody in the public who asks for them. And of course, the insurance industry would not do that. And we pushed the governor so hard through the media that she was kind of had no choice. And she demanded that they, as a matter of contract, agree to that. And they balked. So the governor, or more accurately, her number two person, not the lieutenant governor, the real power, her name was Lisa Moody, pulled the trigger in a really long, rambling press release saying they're being fired because they won't be held accountable to the taxpayers of Connecticut. And so overnight, we thought we won because they were turned into non-risk ASOs, which we have now officially in Medicaid, where they just sort of do prior auth and stuff, but the bills are paid by the state, the single payer in the state of Connecticut for Medicaid. So we thought we won, but in the end, they did an RFP and brought in companies who said they would accept the FOIA obligation. So then it was another 3 years before we ultimately won. Sorry, Ellen, you're forgetting history. It was a painful.
I stand corrected. Yes, I blocked out a lot of it.
A little nuance in there. So the second thing I wanted to mention is that I think the Husky for Immigrants people actually have been pretty successful. Incrementally, yes, but every year they've gotten more. So this year, one of the things that's in my head that I owe people, that some of you on this call know I owe, among other things that I haven't gotten to, is an op-ed that ties together expansion of Husky for Immigrants with Husky C expansion. Husky C is the Medicaid program for elderly and disabled folks, and the income and asset limits are incredibly low. The asset limit was written in 1970, 72, I think. It's just shocking. And so we're trying to get that increased. And the theory in my head is some kind of healthcare justice overriding concept. And then the op-ed, these two are these two legs of it, basically. So that's positive. And we do have a wonderful new chair of the Human Services Committee, Jillian Gilchrist, who is very supportive of all this stuff. She's, as Maggie says, what we expect. She's a social worker. And then the third thing that I wanted to just briefly mention is, since this is the Medicare for All group, is I don't know how many of you have been following at all the trajectory of the Medicare Advantage scam, but it's really fascinating because it has two huge components which appear to be unrelated, but they're integral. And without them working together, we wouldn't have Medicare Advantage. So one of the things is that they make money by, like any insurance company, restricting the private provider network and imposing prior auth. If you're in traditional Medicare, you don't have that crap. I mean, you have the whole network of almost all providers take Medicare. So a tiny few don't, but almost all do. So you got the network. Second, you get prior authorization imposed that is just not generally not done in Medicare. So you're restricted, which is not a problem unless you get sick. Medicare, Medicare Advantage is perfect as long as you're perfectly healthy. Just don't get sick, because then you got a problem. So that's the sort of like the consumer side, harm. But on the other side of it is the financing. And this is what people like the Center for Medicare Advocacy have been focusing on. Ted Doolittle, our healthcare advocate, who actually used to work at CMS, and this is like been a big thing of his, is the fact that Medicare Advantage plans are paid way more than traditional Medicare. Meaning, wait, I thought the whole idea is it's more efficient, blah, blah, blah. No, they get a huge extra bump. With that extra bump, they're able to market that we offer dental, vision, not a lot, but $1,500 a month, $1,500 a year in dental coverage, eyeglasses, 1 pair a year, hearing aids will cover 1,000 towards that, a few other perks. And so they basically hoodwink people into signing up for this thing. Again, as long as they're perfectly healthy, it's great. And one of the things that's particularly pernicious about this particular kind of marketing is that they market that offer specifically to people on Medicaid as well, who already have that, but don't realize that. So they convince them to sign up for something to get something they already had, and in exchange for which they have prior auth and a limited network. Anyway, these two things are related, the consumer side and the financing side, because but for that extra money, they couldn't possibly offer those freebies to get you into the system, and then they restrict you, and then they make more money from that. But the result of all this is that it's projected, I think the end of 2023, I think it's projected that more people in the country will be on Medicare Advantage than Medicare. And this is a brilliant long-term strategy they've had. Just like Ellen and I spent 12 years with all kinds of strategies to get rid of insurance companies and Medicaid, they've had a brilliant, probably 15+ year strategy of how to insinuate themselves through this marketing, these extra payments, into becoming more and more. So they become the norm, and then everybody will say, well, that's what Medicare is, it's insurance companies. I'm only going on this rant because I sent a message to Ted and to Judy Stein today, who runs the Center for Medicare Advocacy, saying, you know what, it'd be really great. I don't know if this is possible, but I said it'd be really great if on a statewide level, we could take this issue on. If we could take on the issue of Medicare Advantage marketing and harm, and I could even do it in my work because I represent people with disabilities. And of course, Medicare is for either people who are 65 or older or are disabled under the Social Security definition. And they are harmed. Their access is harmed as a result of the system, and they're marketed to. And they have brokers. I don't know if people are familiar with the broker situation, but they get a big bounty for signing you up for Medicare Advantage. There's no bounty for signing you up for traditional Medicare. So when you go to those brokers, that's not very helpful. I mentioned this to you. I don't know whether Judy would think there's anything that can be done on a statewide level, because Medicare Advantage obviously is a nationwide problem. Although there are, the plans are different in each state, but the rules are all federal. On the other hand, they are lying to people, they're misleading them in their advertising, and that could be a state law violation under something called the Connecticut Unfair Trade Practices Act. So there might be something to be done, but I decided to throw it out so people could maybe think about it. I'm done.
I see that Patricia has a question, and then I have a comment to that, of course. Oh, and then Phil. Go ahead, Patricia.
So, okay. So I just turned 70. So obviously I have Medicare. I also have Medicaid, Medicare, Medicaid. Before I was able to get Medicare, I had Medicaid. I had Medicaid straight up, plain old ordinary, under 65 Medicaid. And I could get my some vision stuff done with that. Then once I hit 65, now my Medicaid is not so good. I can't get the vision because now I've got the limits. So what do? I have to get a Medicare Advantage. I loathe Medicare Advantage The only positive thing was that if they, well, I can't do it anymore, but it used to be if they pissed me off, I could just, I was taking care of my mom and she had Medicare Advantage, Medicaid, Medicare, just like me. But she had Alzheimer's. When they pissed me off, I would say, okay, I'm changing companies, and I could do it whenever I wanted to. And I would do that. Now it's like, okay, you can only do that once a quarter. I would like to not have.
Not if you're a certain income, if you
No. If you have Medicare, Medicaid, you can
Yeah.
change the Medicare Advantage.
Medicaid, you can switch at any time.
No, they changed it. It's only once a quarter. That's what I was told by, I think it was a Choices guy.
Oh. That's
So,
how long I've been disabled now, because I could switch at any time.
yeah, but they changed it. I think it was just this year even. Anyways, you still can change it more than any other people, but I would like to not have it, except that I need it for dental because my tooth keeps breaking, and I need it for vision. I rarely do them, but I have to, I got to do something because I just don't have the money to do anything otherwise. So it's not just a scam, it's a trap, because I know it's a scam. I know that it's a ripoff, and I wouldn't do it if I had, had any real choice about it. This is why I want an expanded state paid or nation state paid, whatever, I don't care. Just the government should be paying for it, not for military crap. And I am a socialist. So that was the only thing. And I, if we could just do one fell swoop for everybody who lives here, legal, illegal, doesn't matter. You're a human being, you get taken care of. And they want to play these fucking games. And I remember when excuse my language. And I remember, when they were just thinking of this idea of HMOs. And I was walking with, at the time, my spouse, and I was saying, oh, that's a bad idea. If this goes through, it's going to just ruin everything for everybody. And I just knew it, just without even knowing anything more. It's like, they're going to manage it for you? Yeah, I don't think so. And I was right. They should listen to me. Anyways, I don't really have a question except that, I don't know what we can do except yell at them and keep harping at them until we get our way. If anybody has anything more constructive, that would be great, but it's taking too damn long, Sorry.
I don't have an answer. So if anyone can answer that question, please go for it. My other comment was, Sheldon, I hope you can get them to do it on a state level. I don't like, and you know this because of the meeting that we go to together, I think it's disgusting that they train people to become agents of the trusted neighborhoods, Black and brown people specifically, that they train them to become insurance agents, and they're pushing Medicare Advantage. That makes me sick. It really does. It's like you're training them to feed off of the bones of the people. It makes me sick. And I will never help that program. I will help with my opinion, but I will never help spread the information of that specific program because I think it's gross and yet another way to continue to marginalize Black and brown and immigrant communities. It's horrible what they're doing. I'm sorry. Oh, it's helpful. No, it's not. They're getting paid to sell the most expensive things to the people that they're supposed to be trusted for. And yet it's whatever. I'm sorry. You know exactly how I feel about it, but it's awful. I think it's terrible. And Phil, go ahead. You have a question. I think it's an awful program.
Well, I was going to go back to Sheldon's comments about Medicare Advantage and the growth of it as its market share. This is something I've been reading a lot about recently, and my reading was spurred by the fact that My wife talked me into a Medicare Advantage plan last year, and I started getting all of these emails and phone calls. They wanted a nurse practitioner to come to my home to go over my medical record and then coordinate my care with my primary care physician. And what this is a scam to get me to divulge things that will allow them to classify me as having a higher level of complexity, which means their capitation rate for my care goes up. And they're doing this all over. At the same time, there's a study in which they basically did a data search on about 250,000 Medicare and Medicare Advantage patients, and they looked at complexity and at performance of the provider organization in meeting specific criteria that were part of the contract. And what they found was that on the one hand, people in the top tier of complexity, about 70% of them were on straight Medicare, which means that the ACOs don't want those patients, and they're not going after those patients. And one of the reasons is that their performance level compared to straight Medicare went down. The higher the complexity, the worse the Medicare Advantage plans did. So they're getting more money. They're cherry picking patients, and the patients that they do have, they're not meeting the criteria. I'll put the link to that one of those articles on the chat. So that was one thing. I had a question for Ellen. Oh, there she is. You switched on my screen, so I was looking all over my screen for you. And actually a question for anybody. What populations what populations within Connecticut do not have health insurance at this point? And the reason I'm asking that is that I'm guessing that there are a lot of people who work for small businesses who don't have health insurance. And I wonder if it would be worth our time to try to create a program that we would advertise as this is something to help small businesses, something to help people who work for small businesses to have health insurance. And it would be Medicare for all, but it would be targeted at, auto body shops and restaurants and all of these small businesses who have people that either don't have health insurance or they have these gigantic deductible ACA plans, which are not plans as far as I'm concerned. I just wonder if that's something that's ever been discussed in the past and what the reaction to that would be.
Yeah, no, it is. It's definitely small businesses are more likely part-time, but the highest rate of uninsured is among immigrants, and not even just undocumented immigrants, but all immigrants.
Mhm.
People who are
Who are working.
right.
working.
Patricia's right. Gig workers, independent freelancers who they're working but their income varies so much that they don't, signing up for premiums is a hard sell to them because they don't know, even if they could afford it this month, they don't know if they can afford it next month. It's much more likely to be Black and brown communities. So I think all those groups need to be need to hear about Medicare for all. Absolutely. I think, you know, it's a harder sell though, in some ways, because they've got so many other problems that and you know, if you don't have housing, you know that right away. If you don't have healthcare, you don't know that till you're sick. I think getting to employers would help for them to just understand the incredible waste and why they're paying so much more. I mean, I've seen statistics of how much of a, of a car made in America is just, the cost is just healthcare when, you know, when they're made in Canada, that's just not a problem. When healthcare is half the cost, you know. I used to work for the Council of State Governments, and so I had the eastern states, but I also had the eastern provinces of Canada. And when I'd go up there to talk about, you know, how much we're spending, we spend in public money per person about what they do, you know, in taxes for Medicare and Medicaid. It's just the huge amount of private spending that's on top of that, which is like this much in Canada. And that's employers. I mean, it goes through employers. We pay it through our lost wages, but employers could be a lot more efficient. And they could just give up that whole HR section of their entire, you know, business. They just wouldn't have that headache if we had Medicare for all.
Yeah.
Absolutely. Thank
So
you.
is there any interest in, has that been tried here?
I don't know.
Because I think a possible partner for that would be, and I'm surprised I'm saying this because they've never been a good partner or anything, but the Connecticut Business Association.
CBIA.
Yeah,
Good luck with that.
Yeah.
I know.
We've tried to contact them to no avail.
Oh.
We do have a lot of union support, believe it or not.
Sure.
We do have a lot of union support. Good, bad, or indifferent, we do have a lot of union support. I do think that if we were to be able to be in touch with a lot more small businesses, because a lot of small businesses can't afford to stay open because of healthcare costs, or they just have to drop it completely because they can't afford it.
Right.
So I agree with you 110%. And when we were at full capacity here, and we had not the staff because we're all 100% volunteer, excuse me, but when we had an organizer, that's exactly what we did. We reached out to everyone who was affected by this, especially employers, unions. We reached out to everyone. We did not get anything back from CBIA. And I believe 4 of our board members reached out.
The CBIA is conflicted because their main members are the big hospital chains and insurers. I mean, Connecticut's the insurance capital of the planet. So
I see.
Yeah, you really do have to organize the small businesses, and you know, that's a lot of work.
Yeah.
So actually, on that note, I think unless anyone else has any further questions for anyone that have been brought up, I would like to kind of hold on to the, go ahead, Maggie.
Just one more quick question. What's the program that I think the governor, and maybe it was Health Equity Solutions, for those, they created that new category of people that weren't eligible for Husky, but they could buy, what's it called? You know,
Covered Connecticut. Covered Connecticut.
Yeah, what is that? Is that was supposed to do something for businesses and such, wasn't it?
It's basically additional subsidy on the exchange for a narrow band of people within a certain up to 175, I think it is. And it's the same as being on the exchange, except you have more subsidy. People on the exchange have to pay something, right? General for premiums and something for copays. Lower income people get some extra subsidies for copays, but with this additional funding through the cover, it's really ARPA money. It's the extra money came through ARPA, and then in the Deficit Reduction Act, No, sorry, sorry, wrong. The Inflation Reduction Act, right? So that there was more money that came from Congress, so to continue funding this thing. But it's really, I mean, it is more affordable because there's
The
extra
other thing is
subsidies.
it covers dental and vision
Transportation.
and well, transportation, yeah. That most of the plans on the exchange don't cover too. So I mean, it's a good thing. It's free healthcare. You know, why wouldn't you sign up for that? It just, as Sheldon points out, it just doesn't apply to a whole lot of people.
Is that something that we'd want to work on changing the requirements for? I mean, for the people that
It's
Phil's
built
talking
on
about?
it's built on the federal subsidies. That's the way the state could afford it. And the federal subsidies only go up to a certain percentage level. I mean, one good thing the Inflation Reduction Act is sort of softened that out. There's no cliff anymore, but it still goes, you know, your subsidies go down as your income goes up. And so this is like a wraparound that just pays the co-pays and things like that. It's the meat of what the subsidies are federal, and we can't do anything about that.
Okay. But it does provide more services than most of the other things on the exchange.
Yes.
The things that
Oh.
Ellen just said, it's not, I mean, it's not hugely more. It's the things, I think she just identified them.
Dental,
those are like
vision, right?
Yeah.
Yes.
Things that Husky might also cover,
Right.
right?
Right.
Okay.
And just so people know, that not get into this at all, but the background here is that folks have been fighting to maintain Medicaid eligibility for a long time. I'm talking about the Husky A side of things. That's the one with the highest income limit for both adults and kids. And we had been at 185% of poverty, and then we lost it down to, I think, 155, and then we were working over the years to try to go back up, and we got up to 160, and we were trying to go back up higher, and then this was offered as the alternative. And frankly, Medicaid would have been much better because it's more comprehensive, and you don't have to go through insurance companies. The state, you know, runs it, and it's very efficient, and prior authorization is not nearly as burdensome. But this money came along, and we'll say creative people who came up with this idea, some of them were motivated by the fact that they don't like Medicaid. And so they want like the insurance-based, for-profit insurance-based model better. This will put them there instead.
Okay,
Sorry.
that's okay. Were you going to continue, Maggie? Did you have something else?
No, I just wonder if that's something that in the future we wanted to advocate for, to go back to the percentage rates, because that's closer to Medicare for all than this little something in there.
We can't even get them to put a study bill through. Never mind getting a single payer. We'll try as best as we can to help as much as we can to get as much incremental change that we can get right now, no matter what. Trust me, Maggie, we're gonna push through whatever we can with Ellen and Sheldon and everyone else that's working on healthcare reform. We are right there behind them. And as long as you're on our email list, you'll get our action alerts to make sure that you are right there with us, supporting all of these changes, no matter how incremental they may be. I think one of the most important things that I want to say before I let everyone go, even though we may not have gotten through the whole agenda, the most important thing was listening to Ellen and her presentation about this new bill coming through to try to stop consolidation. We here at Medicare for All are in desperate need of an organizer or an activist to kind of take the reins and run, which Miss Yvonne used to have, and she has kind of taken a sabbatical. So if you know anyone who has time to volunteer and would be willing to become a part of us, please email us at info@medicareforall.org. because we really want to make some serious strides here in healthcare justice, healthcare reform, whatever you want to call it, and push things forward here in the state, not just locally, not just state level, but we want to push for federal. And we were able to do that just a few years ago, do all three, and not all of us got burnt out because there were so many of us, but we're left just a handful, and especially not having an organizer has been tough. So if you know of anyone, please email me. You know my work, some of you know my personal, or info@medicareforallct.org. We would love to hear from you. And of course, if you're looking for another board position, we have openings on our board of directors. We'd love to have you. So again, please get in touch with myself or Rana, and we'll be more than happy to talk to you guys. And any ideas for upcoming meetings or anything, please feel free to reach out. And I thank you all so much for your time and dedication to this very, very needed and worthy cause. So I really appreciate you guys so much. Thank you, and have a wonderful evening.
Thank
Good night,
you.
guys.